All right, I assume everything is fine now. So thank you again for inviting me, and sorry for the little technical troubles in the beginning. It's always better to be there in person, but I'm very sorry it was not possible this year. So presentation I chose to do this year is a little bit to reflect on a very important events that happened in air pollution epidemiology or the study of health effects of air pollution, and that is new WHO guidelines. And the whole focus on the low exposure to air pollution as a very strong argument that we need even more strict regulation in EU. And some reflection on how that is affecting also this area in Balkans. So I'll cover slowly a little bit, start with air pollution mortality overview, what is new, present briefly about WHO guidelines. I understand there's a lot talk later also about WHO guidelines, and I look very much forward to hear that. And then I'll introduce also some new studies on air pollution mortality, global meta-analysis, and reflect how they was used for new air quality guidelines, but also show some of these new studies on air pollution mortality that came out and were published after new air quality guidelines, and how well do they agree, and what is the implication of their findings on our understanding of health effects of air pollution, especially at the level below current values. And I have two examples from Danish studies, because those are the ones, as well as this Health Effects Institute study program on low exposure studies from US, Canada, and Europe, as those studies that were published after guidelines. Okay, so how do we define clean air? And we're all aware of the new air quality guidelines that just came out. In old days, for just up until September, we operated with 10 micrograms per cubic meter as the air quality guideline set out by WHO, which was kind of a definition for clean air with acceptance that everything above 10 was harmful for humans, without enough evidence at that time in 2006 to know whether there are effects, adverse effects of PM 2.5 below 10. So now we're down to 5. The new air quality guidelines made this very radical reduction of PM 2.5 to 5, based on evidence that we have health effects all the way down to 5 micrograms. This makes major impact now on our understanding who is exposed to harmful air pollution. And now we know that over 99% of the world population is exposed to PM above 5. So pretty much everybody is exposed to harmful air pollution. At the same time, we have this reality in EU that we have EU limit value legislation much higher, 5 times higher levels of 25 micrograms per cubic meter. And this is up for revision. The air quality guideline, the air quality directive that sets limit values in Europe are actually under revision. There is a public hearing right now that everybody can comment on the EU Commission website. So it's a very exciting time that this new evidence is now being considered by EU for revision and lowering, hopefully, EU limit values according to WHO recommendations or somewhere in between. So also you can see this is from State of Global Air, average air pollution levels by the regions in the world, where you can see huge differences in PM 2.5 levels around the world. The WHO guideline, this is still the old WHO guideline of 10. If you go down to 5, again, we see the clear picture that everybody is really exposed to harmful air pollution. And any reduction in air pollution would bring benefits. If we zoom in Europe, this is 2018, now 19 data is available as well. We see also that most of that in European region, we actually have in the northern part of Europe areas below 5, but very few places. This is usually smaller cities with low population levels. So still a lot of European population is exposed to higher than 5 micrograms per cubic meter. And again, general picture in Europe, and something EEA likes to point out that we have successful legislation, air pollution levels, PM 2.5 and NO2 have gone down in Europe. We see improvements, and that's the good news, but still we do not see improvements enough with respect to health. And this is again the old report, the old limit level now is 5, so still the main point is we see improvements, but we still have significant problems if we follow WHO levels. Serbia is not here. This is only EU countries, but it would be one of the highest included countries in Europe. If you look at NO2, just briefly, although I'll mostly focus on PM2.5 in this talk, also we have seen a very significant reduction in WHO guideline from 40, which is a current EU guideline, EU limit value and guideline from 2006 WHO, that was now reduced to 10. And you can see that has a major impact on our understanding of health effects of NO2, where pretty much most population of EU complied with 40 micrograms per cubic meter for NO2. Now we see a picture that pretty much dramatic change, that most areas do not comply. And that if legislation is to change as dramatically as guidelines, this will have major impact on air pollution understanding and keeping up with legislation. Okay, so I chose Denmark as I want to focus on this low exposure areas because the whole argument to European legislation now is, of course, are there significant effects of air pollution below 25? And Denmark is a perfect example. This is a small country where we see the common monitoring of air pollution in Denmark is based on these 6 monitoring stations. We have 4 background and street stations in these 4 biggest cities in Denmark, Copenhagen, one, and we have 2 background stations or rural stations, so to say. And if you look at NO2, we have some exceedances, of course, even now of EU limit value of 40. But if you go down to 10, again, Denmark is one of those countries where this will have a major impact on perception of how clean air is locally. And what is dangerous. And Denmark has already been sued by the EU because we have exceedances of 40 in some major street stations in Copenhagen. With PM2.5, we have this kind of very typical pictures of low exposure areas in Northern Europe that we very beautifully below 25. So we comply beautifully with EU limit values, and air pollution levels are going down, even in 19 and 20, they're going nicely down. But now with new WHO guideline, we are well above the WHO guideline and what is considered dangerous to health. So we have nice compliance with legislation, but that's obviously not protecting health if we are keeping to WHO guideline to guidance to what is dangerous and what is important for health, what we should be regulating and trying to achieve. So if we go back globally, of course, global burden of air pollution has been increasing. The latest State of Global Air report is what I choose to cite here. From 2015, 4.2 million deaths. Now we have 2019, 6.7 million deaths. This large increase is due to several factors. Of course, we have now better studies. Of course, now with new WHO guidelines, we have seen that the estimate of air pollution mortality association has increased, and I'll show the study in a few slides. Apart from that, we have better understanding of burden of air pollution, and we have new diseases being including in burden calculation. And in 2015, there were 5 causes of death included, and these were COPD, ischemic heart disease, lower respiratory infection, lung cancer, and stroke. And now for 2019 global burden association calculation, they have included diabetes because there's enough good studies to convincingly show causal association, as well as neonatal deaths. And this number shows you attributable factor. So it says about 40% of COPD deaths attributable to air pollution, which is a really significantly high number for any risk factor and so on and so forth for all of this. So in addition of new deaths, new causes of death, new diseases, and better understanding of associations have contributing to this increasing burden of air pollution. Even there where air pollution is going down, we can see increasing number of people dying due to air pollution because of understanding of new diseases, better association, understanding, as well as aging of population that also plays a role in this. We see new evidence, and likely in future, asthma will be added, cognitive disorder, dementia will likely be added in coming years because we have emerging fastly evidence on importance of these diseases as well to death, contribution to deaths from PM2.5. So this contributes, of course, air pollution is rising on the scale compared to other risk factors. Air pollution is number 4 risk factor, just after blood pressure, tobacco, and diet, well above physical inactivity, alcohol, obesity, and so on. So we have a hugely important public health risk factor, comparable and one even stronger than many of the commonly studied lifestyle factors. All right, and now back to a review of the studies. So this is the famous meta-analysis that has been done for WHO guideline. And this was published in 2020 in Environment International with Gerard Hoek and Chen, who were also Gerard Hoek was the author of the 2013 meta-analysis, which has been used in health impact assessment now for many years and has been accepted as the best estimate of association between PM2.5 and overall mortality, and that hazard ratio is 1.06. Now with new estimate, this has gone up, so 33% increase in the estimates. So this estimate is per 10 microgram is saying that there's an 8% increase in risk of premature mortality from any cause for each 10 microgram per cubic meter increase in PM2.5. So, and we see also for other, all these causes of deaths for different diseases, we also see the updated estimates, but we'll focus on this overall mortality. So this has major impact, of course, of all health impact assessment, and we have this increased, stronger association between air pollution mortality now with addition of many new studies and better studies with better exposure assessment, better air pollution models, more countries, more studies from China, and low exposure range. So, you can see here the forest plot of all the studies included in this calculation. So this was the studies, and this is the review of evidence that went into WHO guideline for setting the new guidelines. One important issue, interesting issue that this study raises is that there seems to be evidence that we have likely even higher association in the lower range, that there may be supralinear response curves, meaning that at the lowest levels, maybe below 15 or 10, the curve is more steep, or there may be even stronger association at the lower end. So this paper doesn't conclude it, but brings it up as an interesting observation, which I'm going to comment more on this talk. So another important study I want to bring up is Health Effects Institute has funded 3 studies in their program with explicit focus that was started a few years ago to study what are effects of air pollution on mortality at low levels of exposure to bring this new knowledge. And this was resulted in 3 studies being funded. And LABS is the one in Europe, which I'll talk a lot about, that we were part of with several data from Denmark. MAPLE is a big Canadian study, and Medicare cohort is a big US study. And the whole point here was that earlier, of course, in US, we have a little bit more strict air pollution legislation. 2.5 level is set at 12, while Europe is at 25. But still, even in US, there's an interest whether there should be lower. So these are the 3 studies with PIs Mike Brouwer from Canada, Francesco Dominici from US, and Bert Brunekrepp and from Utrecht from Europe. And quickly, I'll show you just the results of all of these studies. So the DNT study, this is actually part in the meta-analysis, but they found this highly cited paper and very flat dose response curve between PM2.5 and overall mortality of 1.07, so very close to 1.08 meta-analyzed estimate. But main point here, there's a very clear straight line well below 10, which was or 12, or even we're going all the way down to 5 here. So this really shows strong evidence of no lower threshold. Air pollution is dangerous all the way to the lowest level. They also published data on ozone, but I'll focus on PM2.5. MAPLE study published also 2 papers. This one came out from 3 for Canadian census, big Canadian health survey, and they found this estimate of 1.05, also per 10 micrograms per cubic meter. So a little bit lower, weaker association, but also indication of curvilinearity that this estimate is even stronger at the lowest level, below 5 or so. But you can see very low exposure levels in Canada, below 50 for most of the population. Another paper from Canadian group, based on Canadian Community Health Survey cohort, they had 2 types of data and 2 papers were published. They found even stronger association than for meta-analysis, 1.11 per 10 micrograms. And also possible curvilinearity, but pretty linear association as well. Then a labs project was also set out for European context, very important now in light of European legislation revision. This project it's going to answer whether in Europe below 25 micrograms have significant health effects, and how low do they go? Is there a lower threshold? And I'll list some, and just briefly about a lab study. This took a double approach. One was to merge, pull together number of cohort studies all around Europe, and they're listed here in bullet points. And this ended of pooling of the cohort in Utrecht, very centrally at the server, resulted in a strong pooled cohort of 380,000 subjects, and not Canadian and US study could not do this. So this is unique to Europe to have pooled unique cohort data. And another part of the studies had a nationwide analysis, kind of administered analysis that very much what Canadian and American study has done, to look at entire country air pollution association with mortality. So very nice, strong analysis looking at our country, but without possibility to adjust for personal levels, smoking and physical activity and other personal risk factors that cohort studies could do. So this double approach was also facilitated by a very nice air pollution model with a lab study developed. This is a hybrid model developed by Chen Hoek and colleagues that provide European model for PM2.5 and user good. It's actually a hybrid model, satellite data and land use data, which was used in the labs projects and provided comparable data for entire Europe. And these are the cohorts included and the countries that came into the project. And to show some main results. So this is the main paper published in BMJ just recently from pooled cohort analysis. These are the cohorts included in the analysis, mainly Swedish, Dutch, some French, German, and Austrian cohorts. And 381,000 people were included in this analysis. And we have, if you look at exposure, all of the participants in this study were exposed to PM2.5 well below 25, even Swedish cohorts well below 10. So just to show very low levels, as was intention, as well as in PM3.2, most of the people included were well below 40. And this is main results. For overall mortality, the study reports a strong estimate of 1.13 per 5 micrograms per cubic meter. So this is much stronger estimate than one reported in meta-analysis for WHO. So we're seeing even stronger estimates than what was found in meta-analysis in this European study. And the dose response curve shows clear linear relationship below 25 and even below 5, but of course with less certainty. So again, no lower threshold, straight line all the way down to the lowest levels observed in the study. Similarly for NO2, we see this straight line at the ranges below 40, where most people are exposed to, and no evidence of lower thresholds. And again, most of it happened really be in between WHO guideline and EU limit value. Another study was published by Mustafa just now in Lancet Planetary Health. Is not PubMed yet. And this is approach where Belgian, Danish, Dutch, English, Norwegian, and Swiss nationwide cohorts and Rome, just the city Rome, contributed to this analysis. So very powerful analysis with many million people included. Again, everybody exposed below current EU limit values. And this was meta-analysis of these different country estimates, and we landed to 1.05 per 5 micrograms per cubic meter, so also slightly stronger than 1.08 per 10 reported meta-analysis. Here's the forest plot. So we see also, which is interesting, the Danish and Norwegian cohort have some of the strongest estimates. This is again per 5, 14 and 7 per 5 micrograms. So maybe some indication that we indeed see stronger associations in lowest exposed places, this superlinear relationship. And these are those response curves, again, linear, no lower threshold. And then I just quickly point out a few studies in Denmark that also came out after and included in meta-analysis. This is a study from Danish nurse cohort, and briefly, just this is a local Danish model, different than labs model. We found 1.14 increase per 10 micrograms, again stronger than what meta-analysis reported. And also lower, if we go down below 25 and 10 and 50, we find even stronger association. Also, correlinearity was detected. Another Danish study from Danish Cancer Health cohort also finds very strong association. This is also slightly different air pollution, different cohort. Agree that we find stronger associations to observe meta-analysis in Denmark. Again, quite linear associations on the entire exposure range. And the third nationwide Danish studies also found 13 per 10 micrograms association, strong study, entire Danish population, consistent with 3 other Danish studies, associations are stronger than what we see in meta-analysis. So to put all this together, I have converted all the estimates here per 10 micrograms per cubic meter. So the main story here from old estimate 1.06 to new 1.08, which was done for new WHO guideline, we have increase in, we know now that there is a stronger association between air pollution and mortality based on existing studies. And this is very well supported with studies that are focused just on low areas. The Labs Project European, stronger, both these papers find strong association. Maple, very much agreeing, against meta-analysis in US studies. And then we look at some newer studies that were published, for example, for Denmark. Since the major guideline, this is very much in line with the Labs Project that we find associations in range between 10 to all the way to 28 per 10 micrograms per cubic meter, and likely curvilinearity, so stronger association, low exposure range. So to conclude on my talk, so we have really strong, convincing new evidence of adverse health effects below current EU limit values in agreement with new WHO guidelines. And this is really extremely strong case for stricter regulation in Europe. Maybe we have even stronger association at low levels. This is likely that this curvilinearity is being observed with the newest studies coming out. We know that EU Commission, with new EU Green Deal and the new revision of Air Quality Directive, that we're excited to see what's going to happen in 2022. European Commission is committed to incorporate this newest evidence to revise the Air Quality Directive and set the new limit values. And we as a research community really call for full alignment of EU quality standard with WHO guidelines. There would be really, there is no reason, there's no lack of evidence of certain not to do that, but we'll see what comes out of negotiations. And of course, this all has major impact on all new health impact analysis. What is the burden of air pollution? As I said, even before these new estimates, the global burden of disease analysis showed increased burden of air pollution. Now with these new strong studies and new estimates of association with air pollution mortality, we know that number of deaths around the world will even increase due to air pollution, even if air pollution levels are going down, with this new understanding how dangerous air pollution is. And just to mention, I recently presented this at Air Quality EU Clean Air Forum just last week in Madrid, Spain, and we also made these points directly to European Commission, who organized the meeting, with the health burden really being unacceptable, and in full support for acceptance of WHO quality guidelines as EU limit values. And we made also very important that these policies would very much contribute to mitigation of climate change crisis. And I think a lot in our air pollution burden communication, we need to make a very strong point in benefits in policies that would tackle climate change and air pollution at the same time. And I just want to give you a link here to 2 recent reviews. We wrote a statements which kind of cover this, so full support to new WHO guidelines and call for European politicians to implement them. And you can see links. And we made also a nice statement where we included a lot of medical societies. There's still your countries, and Serbia, I think it hasn't been still endorsed by medical societies. Only one Serbian has, but you can still use this document, and it's still a living document, and we have over 140 endorsements for medical societies and translations in all the languages. We have done them in Serbian, Bosnian, Macedonian, and so on. So if you're more interested in this, please contact me or find the link so you can communicate this even more locally, importance of new guidelines for future legislation. All right, and I'll end here. Thank you very much, and I'm sorry for some hiccups in the start of the talk.
Thank you very much, Professor Jovanović Andersen, also for being on time. You helped us to stay in the foreseen time schedule. I ask all the people here in presence and being connected remotely if there are any questions. If there are no questions, I would ask you if you could comment some on how this decreased.
And I cannot hear if there is a question now, so maybe you can write it. If I put my volume up again, there is echo.
Okay. If you can comment on this feasibility of reaching this 5 microgram per cubic meter in Southern Europe and Central Europe. Yeah. Yeah, I wrote message and yeah. It's a stupid question, but it's very yeah. Okay. Can you go so thank you, Professor Jovanović Andersen, and we keep on with our schedule.